Hi friends, so in this video we are going to be talking about neuroradiology. It's a very important system because like GI you do get a lot of integrated questions from this topic. The focus areas that we are going to be talking about, one, it's going to be head trauma, the most important thing where you get so many questions. So head trauma, always one question is there in every exam. After that we talk about stroke and vascular pathologies of the brain. After that, we are going to be talking about the brain tumors. An integrated approach with PATH is what we shall be doing. And then there are few miscellaneous signs and CNS infections also that we want to be discussing. Okay, so this is going to be the approach to neuroradiology. Let's start off with the first most important part, that is head trauma. So when we are talking about trauma to the head, the first investigation and the best investigation remains the same. So there's one investigation that is going to be the central role. It's NC-CT, which is a non-contrast CT of the brain. Why non-contrast CT? We also talked about it in the thumb rules, but why non-contrast CT? Because here we want to be ruling out hemorrhage. Our main focus area is to look whether there is bleeding or not. And we know acute hemorrhage is hyperdense. It is white on CT scan. So that is why we don't have to give any contrast. So we do a non-contrast CT scan of the brain. It is a very quick investigation. That is why it is the one-stop solution that we have for imaging head trauma. There is one exception here though that we shall be talking about. I'll just mention it right away so that you can remember. So the only exception where MRI is the answer is a condition called DAI, that is diffuse axonal injury. So diffuse axonal injury is the only condition wherein MRI is going to be better than CT. Everywhere else it is NC-CT, which is the investigation of choice. So now when we talk about head trauma, I just want to give you a brief classification or overview so that you have that picture in your mind. So when we have head trauma, the injuries can be classified into extraaxial, which is outside the brain parenchyma, or intraaxial, alright, which is within the brain parenchyma. Extraaxial blood collections could be with respect to the meninges into various compartments, right? So we have dura, we have arachnoid, and then we have pia mater, which is outlining the brain. So we have dura, we have arachnoid, and we have pia mater, right? So if there is bleeding, let's make bleeding with red. If there's bleeding outside the dura, meaning between the skull and the dura, if you're bleeding, we call that extradural hemorrhage, EDH. If you're bleeding between dura and arachnoid, we call it subdural, below the dura, subdural hemorrhage. If you're bleeding between arachnoid and pia, that is subarachnoid hemorrhage. Okay, so there could be bleeding in these three compartments, or extraaxial, it could be in the ventricles, which is intraventricular hemorrhage, right? So there are these four areas where we have bleeding outside the brain. How do we identify them? I'm just going to give you one trick which is going to solve all of our problems in diagnosing them. So first of all, acute bleeding, it's going to be white. So that is sorted, acute hematoma, white. Now look at the shape. The next step you have to process in your mind is the shape. If you see that the shape is like a lens or like an idli, yeah, you know idli? So idli for EDH. Okay, so if it's like an idli or a lens or a biconvex shape, that is EDH for you. If the shape of the hematoma is like a crescent or a banana, then it is SDH. If the shape of the hematoma, you are seeing it in the basal cisterns and it is shaped like a star, that is SAH. And if it's within the ventricles, it is IVH. Okay, so you see the shape. If it's like an idli, EDH. If it's like a banana, STH. If it's like a star, SAH. Within the ventricles, IVH. Okay, so I think this diagnosis is sorted. Then within the brain, when you see bleeding, so if this is the brain and you are seeing that there are these bleeding foci, you want to see the size. If there are large bleedings with heterogeneous edema surrounding it, we call that contusions. Okay, so that is called as cerebral contusion. Please do not confuse this with concussion. Concussion is something wherein the brain imaging is normal. Alright, so concussion is an injury wherein you do not really have any abnormality on the CT. Okay, so remember contussion, contusion, don't get confused. So contusion has a letter C. Yes, you can remember contusion is what you can see on CT. Yeah, so that's a convenient way to remember that contusion can be seen whether concussion is not seen on CT. So when you have intraaxial hematoma, that is contusion. The other example of intraaxial injury is going to be diffuse axonal injury, wherein they would give you that the CT either is normal or is showing you very tiny particle hemorrhages, and that is where MRI comes into picture. Okay, so these are broadly going to be the subheadings under which we shall be looking the images for head trauma. Okay, so this is about the classification. So let's begin now with extraaxial hematomas. So in this CT, we can see two kinds of hemorrhages. So first of all, right and left, I hope that is sorted for everyone. So here on the right side, what we are seeing is a hematoma. In acute hemorrhage, it is hyperdense, which is shaped like a lens. It is biconvex, yeah, or I can say idli shaped. On the left side, there's also a hyperdense hematoma, and the shape of which is like a crescent or a banana, isn't it? So, what are these? So, on the right side, what we have is an EDH, extradural hemorrhage. On the left side, what we have is an SDH, a subdural hemorrhage. Okay, so before we go into this, let's document all of the pointers that you need to know from where you can get any possible question. So remember, the type of trauma is very different. In EDH, you need a high energy trauma. So you would have history of some sort of a road traffic accident which is there, whereas in subdural hemorrhage, remember, what you have is a trivial trauma. So here you would get history that maybe there's an elderly patient who's had a bathroom fall, or this could be seen in boxers, in alcoholics, who can have frequent falls. Okay, so EDH versus SDH, the type of trauma is different. The type of injury is again very different. In EDH, you have arterial injury, and the most common artery to be injured here is the middle meningeal artery. And also an anatomy correlation for you, middle meningeal artery runs beneath the pterion. Yeah, it runs beneath the pterion. That is why when you have pterional fracture, there is very high association with EDH. So the most common site here is pterion when you have associated pterional fractures. Okay. Whereas SDH happens when you have injury to the bridging veins. So this happens when the bridging veins are injured, and this is along the cerebral convexity. So the most common site of SDH is along the cerebral convexity. Okay. Apart from that, something called as a lucid interval. This is a repeat question. Where do you see a lucid interval? So first of all, what is lucid interval? So let's say after the trauma, the patient lost consciousness. After that, when the patient regains the consciousness for a brief amount of time and then again loses it, that brief regainment of consciousness, that period is what is called as a lucid interval. Okay, so remember, this regainment of consciousness between two periods of LOC or loss of consciousness is defined as lucid interval, and that is what is seen in EDH. Can it be seen in SDH? Answer is yes, it can be, but it is more specific for EDH than SDH. Okay, so that is what you want to remember. As far as shape is concerned, we have already documented that. So biconvex is EDH, biconvex or lens, whereas a crescentric concavo-convex is going to be SDH. Now, why the shape? The shape is because of the next two pointers. So EDH, it is between the bone and the dura. The dura is very firmly attached at the sutural sites. So let's say this is the bone, this is the dura. When you have bleeding outside the dura, it is not going to be able to cross the sutures because the dura is attached at the sutures, and that is why this shape, which is that of a lens, occurs. So remember, EDH cannot cross the sutures, whereas it can cross the midline. On the other hand, because we have the dura attaching at the midline, the SDH is able to cross the sutures but is not able to cross the midline. So now one more time, if you look at the CT on a cross section, this is approximately where we have the sutures. Okay. So you can see how the EDH, because the dura is attached to the sutures, this hematoma cannot cross the sutures, but if an EDH is somewhat like this, it can cross the midline. On the other hand, an SDH, remember, is something which can easily cross the sutures, but it will not be able to cross the midline here. Okay, so that is something that you want to remember. So easy way to remember is everything can cross only one thing. Okay, so S for SDH, S for sutures, it can cross the sutures, but it cannot cross the midline. Okay, so this is about the possible questions on EDH and SDH. Now, as far as symptoms are concerned, remember, because SDH has higher area or higher volume where it can go into, it very rarely produces mass effect on the brain. Whereas because EDH is localized to this compartment, it has higher chances of causing mass effect on the brain, and that is why we need to decompress EDH. Okay, so there are various indications of performing a decompression surgery in EDH that we'll learn in surgery. But radiologically, one very important pointer which I want to give you is the swirl sign. So when on the CT, you see that in a hematoma, there are these hypodense areas and hyperdense areas. That tells us that there is presence of active bleeding. Means there is different age of bleeding. Some of it is acute, some of it is chronic, means it's been going on for a while. Yeah, and there is area of active bleeding. So when you see these heterogeneous sort of a density within a hematoma, that suggests that there is active bleeding which is going on, and this is an independent indication of decompressive surgery. Okay, so remember swirl sign, when you have hypodensity within the white hyperdense hematoma, that is what is called as the swirl sign. Okay, now going ahead into the next hematoma. So we've done EDH, SDH, now we have the star, right? So the star is SAH. So you can see how here we are at the level of the basal cisterns. So this is the midbrain, these are the two cerebellar hemispheres, and this is where you have the basilar cisterns, and this is where the circle of Willis actually runs. Okay, so when you have a hematoma here, this is in the subarachnoid space. So this is subarachnoid hemorrhage, and this is called as the star of death. Okay, so this appearance, because it has such a poor prognosis, has been called as the star of death appearance. Okay, so the diagnosis here is acute subarachnoid hemorrhage. Now we're talking about trauma. So trauma overall is the most common cause of SAH. But here what is also very important for us to discuss is spontaneous SAH. What about SAH that happens in patients who do not have trauma? So overall, yes, trauma is far more common. But when we talk about non-traumatic or spontaneous SAH, the most common cause is berry aneurysm rupture. Okay, so we have aneurysms which can form in various arteries of the circle of Willis, and they can rupture to result in subarachnoid hemorrhage. And now we will talk briefly about this scenario. So how will these patients present? So these patients are going to present with this acute onset headache. This is likened to be a thunderclap headache. Thunderclap as in it reaches crescendo within seconds and minutes, right? So it increases in severity very quickly. The other phrase which is very typical is worst headache of my life. That is what the patient is going to tell you. So very severe thunderclap headache, which could also have other signs such as neck rigidity. You can also have the Kernig sign, Rudinsky sign that we study in meningitis being positive here, because this blood which is accumulating can actually irritate the meninges and can give rise to these signs of meningitis as well. Okay, so the clinical feature, the buzzword here is going to be the thunderclap or the worst headache of life history that the patient can give you. Okay, so this is about the clinical feature. Apart from that, what is the most common site where these aneurysms happen? So when we have the circle of Willis, it is at the junction of the ACA and ACOM. It is at this junction that the aneurysms are more common. So ACA, ACOM, anterior cerebral, anterior communicating artery junction, is the most common site of berry aneurysm. Like any acute hemorrhage, the initial investigation you want to do in such a patient is NCCT. When NCCT shows you the star of death appearance, you know that it is SAH, and then you go for the next investigation to rule out an aneurysm. We need to give contrast. Yes, we want to see the aneurysm from the artery, so we have to give contrast, and because we are seeing the artery, the investigation of choice becomes a CT angiography, right? So CT angiography meaning we are giving contrast and we are visualizing the vessels. Okay, so in this we will be able to diagnose that okay, there is this outpouching which is there, which is sign of aneurysm. What is the gold standard? So we know gold standard is something that is diagnostic and therapeutic. In this case, that is DSA. DSA is digital subtraction angiography, right? So this is a modality wherein we are going to go inside the arteries. We will puncture most commonly the femoral artery. We'll go with our catheters and wires into the arch of aorta. We'll go into the carotid artery. We'll go into the ICA, and therein we'll inject contrast, and we see something like this. So when I'm putting contrast in the internal carotid artery, we can see how it is going into ACA and MCA, right? So ACA is the anterior branch, whereas MCA is the lateral branch that you can see here. And within this, you can see how in the anterior cerebral artery, there is this outpouching, which is the aneurysm. So in this DSA image, you can see an ACA aneurysm being shown to you. Okay, so this has also come in one of the INI CT exams as an image. So this is what an aneurysm looks like. It is this outpouching of contrast that is there. Okay, so remember, DSA is when you are inside the artery, so angiography, and you are subtracting the background digitally so that the vessel can be seen very nicely. Okay, now how is this therapeutic? So we've already entered the artery. Yeah, we are in the vessel. So endovascularly through our catheters, I'm going to send in a coil. Okay, so what we do is, let's say this is the aneurysm. Through the artery, we will send in these coils inside the aneurysm, and these are metallic coils, and what they'll do is they'll result in fibrosis. They'll cause thrombosis and further fibrosis of this aneurysmal sac, and it will block it. Okay, so this process is called as coiling. Okay, so coiling is now the most accepted treatment of choice for aneurysm. Apart from this, surgically as well, the surgeons can do a clipping of the aneurysm, wherein outside the aneurysmal sac they're gonna put in a clip and block it, but obviously that is far more invasive. So nowadays coiling is the preferred method of treatment, and that is why the gold standard is DSA, which can confirm the diagnosis and also offer therapeutic coiling. Okay, so this is everything in a slide that you need to know about SAH and aneurysms. Okay, so SAH, trauma more common than berry aneurysms. We know the clinical manifestation. First you do NCCT, CT angiography, and then DSA. Okay, next we want to talk about the last extraaxial bleeding, which is inside the ventricles. So in this image you can see how there is white hemorrhage, hyperdense hemorrhage inside the lateral ventricles. So this is IVH, which is intraventricular hemorrhage, which can happen because of injury to the ependymal vessels. Okay, so this is intraventricular hemorrhage. Now going into intraaxial in the brain parenchyma when you have injury. So in this CT scan you can see how within the frontal lobe you have these white hematomas with surrounding edemas. So this is contusion. So this is cerebral contusion. And remember, the most common site for cerebral contusion are going to be the frontal and the temporal lobes. So you can see how the basifrontal, basitemporal lobes are more commonly involved in contusions. And why is that so? It's because you have a lot of bony projections here. So you have the sphenoid bone here, you have the petrous apex of temporal bone. So because in trauma you have the impaction of these bony projections with the brain at these sites, that is why you have higher resultant hematomas and contusions which can result here. Okay, so remember, contusion are these hematomas which can occur. So they are going to be hyperdense with surrounding edema. Secondly, the most common site is going to be the frontal and the temporal lobes because of the bony processes here. And what you want to remember is they are also associated with coup, counter coup mechanism of injury. What is coup counter coup mechanism of injury? So herein, anytime there is impaction in a closed compartment, right, like the brain, what will happen is, let's say there's impact here. So if there is impact here, there's going to be an injury on this side, so there's going to be injury on the right side, and along with that, because of the shaking, you will have an injury diagonally opposite to it. So if there's impact here, this part and then this part, both of them are going to have impaction. So coup counter coup mechanism of injury. So whenever you have contusion here, you should always rule out some sort of an injury on the diagonally opposite aspect. Okay, so this is about contusion. I already told you, don't confuse it with concussions. Okay, so these are contusions. Next, we come to the most important question for the exams. Again, just like we talked about perforation in GI being so important, in neuro, it is diffuse axonal injury which gets you questions, almost every exam. So herein, what they'll give you is a history, which is a very standard template history, wherein they'll tell you that there's a patient who underwent a very severe road traffic accident. After this, his GCS is very low or the patient is comatose. When we went for the CT scan, that was normal, or it showed minor petechial hemorrhages, something that does not explain the degree of low GCS or the neurological status of the patient. So in this case, you want to rule out the entity, that is DAI, diffuse axonal injury. Okay, so the diagnosis is diffuse axonal injury, which is DAI, and the history which I just told you. So the clinical feature would be high energy trauma, and the patient would either be given as comatose or having a low GCS score. NCCT would either be normal or show you these minor small petechial hemorrhages. So what is going on? In DAI, what you have, as the name suggests, is the shearing, is the tearing of the axons because of the high energy trauma, and everywhere these axons get torn, you will have these small micro bleeds, you will have these micro hemorrhages, which overall lead to a very poor neurological outcome. Okay, so remember, this is what is diffuse axonal injury, and to pick up these micro bleeds, we need a high resolution imaging like MRI. So this is the only place in head trauma where we have MRI as the investigation of choice. Okay, so MRI, and further in MRI, what sequence? It is SWI. I have talked to you about this in MRI chapter also. So SWI is the susceptibility weighted imaging. So susceptibility weighted imaging, SWI, is the sequence of choice in MRI, because herein the bleeds, wherever you have bleeding, will show as these black foci, which is called as blooming. Okay, so these are foci of blooming which are going to be presenting on SWI as these black spots. Okay, so these foci of blooming represent micro bleeding. Okay, just for an extra edge, this has not been asked, but for an extra edge, we also have a classification, which is the Adams staging of diffuse axonal injury, wherein you have 3 grades with increasing severity. So grade 1 is when these bleeds are in the gray matter white matter junction. Okay, so it's in the cortex, parenchyma, gray matter white matter junction, that is type 1. In stage 2, what you have is bleeding within the corpus callosum, and in grade 3 you have bleeding in the brainstem. All right, so as we increase in the grade, the prognosis becomes more and more poorer. Okay, so this is what you need to remember about diffuse axonal injury. The next part that we want to talk about in trauma is when you have air accumulating in the brain. Okay, so how does air come inside the brain? So one, this could either be because of some sort of an open fracture, or it could be because of associated sinus injuries, right? So if you have the frontal sinus, or you have the mastoid air cells getting injured, there's a fracture there, the air can come inside the brain. So if there is some amount of air, we call it pneumocephalus. But then when you see an appearance like this, where the frontal lobe is under pressure, can you see how there is this tethering of the cortical veins, because of which this kind of looks like a mountain. So this appearance has been given the name of Mount Fuji sign, and this represents tension pneumocephalus. It means that the brain is under pressure, there is tethering of the veins, and the frontal lobe is pointed like this. So this is a sign which represents tension pneumocephalus, and this is the Mount Fuji sign. Okay, so this is what we had to discuss as far as head trauma was concerned. Next, we talk about stroke. So within stroke, first we shall be dealing with the approach and the imaging of stroke, and then we'll see some other vascular anomalies of the brain. Okay, so in stroke, very important, something that you will study in detail in medicine, I will teach you the diagnostic algorithm. So the most important thing, what is the first investigation that you will do in a patient of stroke? So the first investigation is a non-contrast CT. Just like we saw with head trauma, NCCT is the first thing we will do, and again the same rationale is to pick up acute hemorrhage. There's nothing better than CT, nothing quicker than CT to pick up an acute hemorrhage, alright. So that is why we are doing an NCCT, not to pick up the ischemic stroke but to rule out hemorrhagic stroke, okay. So when we say stroke, I mean any focal neurological deficit which is not reversible. That is the definition of stroke, a focal neurological deficit, any deficit in the brain that is non-reversible. Yeah, and it happens either because of hemorrhage or because of ischemia. So some sort of vascular pathology is there which is resulting in reduction of blood supply. Yeah. So here the NCCT, the main job is to rule out hemorrhagic stroke, alright, because ischemic stroke or infarct is something which is not very sensitively picked up on a CT scan, especially in early cases, okay. So that is why if asked what is the best, most sensitive investigation for an infarct, answer is going to be diffusion weighted imaging. So diffusion weighted imaging is the most sensitive investigation overall for an infarct, but then we do not really do it unless we are in a dedicated stroke center, because MRI is not very readily available. It is time consuming, right? So time is very crucial in stroke. We call it time is brain, right? So time is very crucial. So in the actual protocol, you will see DWI doesn't really figure unless we are in a very dedicated stroke center wherein you have MRI on standby for patients of stroke. But when we discuss the algorithm, we are going to be talking about NCCT. So I hope this is clear to you that overall what is the most sensitive for picking up ischemia? It is diffusion. It can pick up stroke as early as 30 minutes after the onset. But then when we talk about the algorithm, our go-to investigation is going to be NCCT. Okay. So any patient of suspected stroke presents to the hospital, what is the first thing that we are going to be doing? The first thing is going to be NCCT. Why NCCT? We will rule out our hemorrhagic stroke. You see acute hemorrhage, you rule them out of the protocol. So hemorrhagic stroke is sorted. Now any patient, whether CT is normal or showing you signs of ischemia, all of these we now have to see whether they fall in the window period or not, or whether there are any contraindications to thrombolysis or not. Okay. So if they fall in the window period, all of this is going to be discussed in medicine, or if there are any contraindications through thrombolysis, again you rule them out. If none of this, if both are fitting, then they undergo IV thrombolysis. Okay, so then the next step is going to be IV thrombolysis. Now, if the patient is not in the window period, if IV thrombolysis is not possible, in that case, we need to do two investigations, which are CT angiography with CT perfusion. What is CT angiography and CT perfusion? So in CT angiography, we will be injecting contrast and looking at the vessels to see which vessel is blocked. Here we are trying to see whether it's a large vessel stroke or not. In CT perfusion, P for perfusion, P for penumbra. We are trying to look for the presence of penumbra. What is a penumbra? It is an area of salvageable tissue. So it is an area which is not yet infarcted, it is ischemic, but it is not yet infarcted, means it is salvageable, it can be saved. So I want to fulfill two things. One, there is a large vessel stroke, and second, there is a penumbra. If these are fulfilled, then we can go ahead with an alternative form of treatment, that is endovascular management. So we can do intra-arterial thrombolysis, or we can do a mechanical thrombectomy. So here intra-arterial endovascular procedures are possible. Okay, so this is the flow chart in a very simplistic form which I want to tell you. So NCCT is what you do first. Radiologically, what comes next is CT angio and CT perfusion. If IV thrombolysis has already not been done, if that's been done, well and good, the protocol stops there. Okay, so this is about our approach to a patient with suspected stroke. Now, I did tell you that NCCT is very useful for picking up hemorrhagic stroke, but can it have any signs of ischemic stroke as well? Answer is yes. So in cases of ischemic stroke, the other signs, these are not very sensitive, but the signs that can be picked up, one, you can have this edema. So you can see how there is this hypodensity which represents the cytotoxic edema of the brain tissue. In this case, you can see the vascular territory of MCA being involved. So this is an MCA territory ischemic stroke, right? If the hypodensity was anteriorly like this is the ACA territory, right? And if the stroke is here affecting the occipital lobes, that is the PCA territory. In the brain, you know, different arteries have their vascular territories and there are watershed areas here. So this is anterior cerebral, middle cerebral, posterior cerebral artery vascular territory. So the edema can actually help us diagnose the artery also which is affected. Okay, so this is one wherein you can see this edema. The second sign is the vessel on the non-contrast CT can appear hyperdense because of the acute thrombus being hyperdense, and this is what we call as the hyperdense MCA sign, which is a sign of the acute thrombus in this vessel. Okay, so these are subtle signs of ischemic stroke that can be picked up in certain cases, but it's not something which is very sensitive. Okay, what is the most sensitive investigation to pick up ischemia? As we have discussed, it's diffusion weighted imaging. So we have discussed the concept in MRI, wherein we are actually picking up the cytotoxic edema which results in diffusion restriction. The diffusion of the water molecules here is restricted, so there is diffusion restriction in the infarct, right? So infarcted tissue is going to show diffusion restriction, and how that's going to appear is it's going to appear white. Okay, so first of all, how do you recognize this as DWI? Is you will not see the bone and the fat outside. Okay, you just see the brain, you know it's DWI. And DWI, anything which is white on diffusion weighted imaging is your diffusion restriction. So it has to be hyper intense on DWI. In addition, DWI always comes with another image which is, you know, machine generated, that is called ADC. ADC stands for apparent diffusion coefficient. Apparent diffusion coefficient, which is actually just gonna tell you that whatever was white, hyper intense on DWI, if it becomes hypo intense on ADC, this is what we say as true diffusion restriction. So any stroke would be white on DWI and dark on ADC. Don't really worry too much about it. You just want to remember infarct shows diffusion restriction. Okay, we talked about penumbra and we talked about CT perfusion. So CT perfusion, as the name suggests, is what tells you the microdynamics, the vascular dynamics of the blood flow in the tissue. Okay, so we take three parameters, we measure three parameters in the perfusion study. One is the cerebral blood flow, second is the mean transit time, and the third is cerebral blood volume. Okay, so these are three images which are generated. So let's have a look here. Here you can see how in this particular area the cerebral blood flow is deranged. Mean transit time is also deranged in this, but within that cerebral blood volume is only deranged in this area. So what does that tell us? So remember, we have something called as infarct core, which is completely infarcted tissue, and then we have penumbra, which is ischemic. It has vascular insult, but then it is still salvageable. If we revascularize, this tissue can be saved. Okay, so that is called as penumbra. So if we have a look here, you can see how if there is an ischemia here, this black part is the infarct core, whereas the outer salvageable part is what is called as penumbra. Okay, so whenever you have some sort of vascular occlusion, you will have these two areas being affected. Okay, so what happens in the infarct core and penumbra? Overall, because of vascular narrowing, the mean transit time, the time taken for the blood to course within a particular amount of tissue, it's gonna increase because there's narrowing. So mean transit time increases in both. Cerebral blood flow. Again, because of the vascular occlusion, blood flow reduces in both. So how we distinguish it is on the basis of cerebral blood volume. Infarct core definitely results in reduction of blood volume, but in the penumbra, this volume is going to be maintained. In fact, it can also be increased. Okay, so what we look for is a mismatch. What is the mismatch? So look at these images again. When we see that flow and mean transit time, it's this entire tissue which is affected, and blood volume, only this tissue is affected, can I say that the rest of it is all salvageable? There is a mismatch. Yeah, so all of it is the penumbra. So on CT perfusion, what we are actually trying to understand if whether penumbra is present or not. Okay, so that is what we are studying. At your level, what you want to remember is any colorful images is perfusion, and PE for perfusion, PE for penumbra. Okay, this is something that you can just maybe understand for once, but is not been tested so far. Okay, so this is what we are doing with stroke imaging. Now let's talk about lacunar stroke. So far we have seen large vessel stroke wherein we have ACA, MCA, PCA being affected. When you have the smaller branches of these vessels getting affected by an ischemia, that is what we call as a lacunar stroke. It is a low volume stroke that frequently affects the gangliocapsular region, which is this area of the basal ganglia internal capsule region. Okay, so there's a low volume stroke. You can see how there is this small area of hypodensity here in the region of the internal capsule. So this affects the gangliocapsular location, which is the basal ganglia internal capsule location, and the most common artery to be affected, like you can see in the schematic, this is the ICA giving rise to ACA and MCA. So this is the MCA, which has these lenticulostriate branches. So the most common vessels to be affected here are the lenticulostriate branches of MCA, and these small branches undergo this narrowing that is referred to as lipohyalinosis. Pathologically also can be called as microatheroma. So lipohyalinosis or microatheroma formation results in the narrowing and further ischemia of the basal ganglia. Okay, and this is what actually results clinically in what we call as dense hemiplegia. So this results in dense hemiplegia wherein you do not really have cortical signs which are present, but you would have a lot of body functions which are undergoing impairment because of so many corticospinal tracts becoming denser and concentrated in internal capsule. Okay, so this is about lacunar stroke. Radiologically, you will see a very small area of hypodensity defined as any volume less than 15 mm in diameter. Okay, so 15 mm in diameter or smaller is lacunar stroke. Now we talk about venous stroke, and with that I just want to take the opportunity of drawing a parallel and teaching you three empty things. Okay, so there are three empty signs that we learn, all of which are independent questions in themselves in neuroradiology. So what are the three empties? So first let's finish the topic of stroke and teach you the third image, which is called as empty delta sign. So when we do a CECT, when we do a contrast enhanced CT, the vessels are going to appear white. Yeah, so you can see how all of the vessels of the brain are appearing white, but then you can see how here, which is the superior sagittal sinus, in the cross section you have, when you take a cut through the superior sagittal sinus, you will see that there are two triangles anteriorly and posteriorly, which you see. In this case, you can see how this posterior triangle is having this black defect, which is a filling defect, isn't it? So this is what is called as an empty delta sign, which represents a thrombosis of the superior sagittal sinus. So this is seen in superior sagittal sinus thrombosis, or for that matter any venous sinus thrombosis, we are going to have this filling defect on a contrast enhanced CT. Okay, so this stroke is your venous stroke. We already talked about arterial stroke, yeah. Now we are talking about venous stroke, where you have venous sinus thrombosis, and this is frequently seen, you know, in history of OCPs, or you could have a child who is having dehydration. So those are various risk factors which could be given to you. Okay, so that is the first empty. Apart from that, you can have a history that there is a postpartum female who has a history of postpartum hemorrhage. PPH ka history is something which is going to be a clincher here. So they'll give you history of postpartum hemorrhage, and they'll tell you the buzzword, which is failure to lactate. So there's lethargy, there's failure to lactate. After a history of PPH, the diagnosis here we are talking about is called Sheehan's syndrome, wherein you have necrosis of the pituitary. There is ischemic pituitary necrosis, because pituitary needs a lot of blood supply near the purpurium, and when you have a PPH, when you have a shock status, you will have necrosis. So the pituitary undergoes ischemic necrosis. It is very, very susceptible, and when that happens, when you look at the image of the sella, what you would see is, this is the sella here. The sella is only showing you white fluid, you know, World War II. So this is all CSF which is occupying the sella, and the pituitary is just not seen, isn't it? So this is the stalk of the pituitary, and the pituitary parenchyma is missing. So this is what is called as empty sella. So empty sella sign is going to be seen in Sheehan's syndrome. So two empties, empty delta, empty sella. Empty delta is superior sagittal sinus thrombosis, empty sella is Sheehan's syndrome. The third empty, which is an Ames question, is empty thecal sac sign. So here I am showing you the MRI of the vertebra. This is what a normal vertebral axial section would look like. So this is the thecal sac, this is the spinal canal at the level of phylum terminal. You can see all of these nerve roots. This is normal. But in cases where you have arachnoiditis, okay, where you have inflammation, what would happen is all of these nerve roots get adhered to the inflamed meninges, right? And you see that no nerve roots are seen in the thecal sac, and that is why the name empty thecal sac sign, which is associated with arachnoiditis. Okay, three empty signs clubbed for you: empty delta, superior sagittal sinus; empty thecal sac is arachnoiditis; and empty sella is Sheehan syndrome. Okay, so this is about the venous stroke that we were discussing. So now within stroke, what all we have done? We've done large vessel ischemic stroke, we've done small vessel ischemic stroke, that is lacunar stroke, and we've done venous stroke. Now we go into hemorrhagic stroke. Remember, hemorrhagic stroke is what we were diagnosing very reliably on the CT scan, right? Because we know acute hemorrhage, it's going to appear white, it's going to appear hyper dense. So that is what we are seeing here. We can see that there is this acute hyperdensity in the basal ganglia. So this is what we say as acute hemorrhagic stroke or acute intracranial hemorrhage. Where is this happening? What is the most common site? So for that, some bit of anatomy we need to revise. So here what we are seeing is along the two horns of lateral ventricle, the basal ganglia that we have is the caudate nucleus. Yeah. Then you can see how there is a lentiform nucleus. So this is the lentiform nucleus, which is made up of two parts: outer putamen and inner globus pallidus. And you can see how here the putamen is undergoing hemorrhage. There is hemorrhage in the putamen, isn't it? And on the two sides of this midline third ventricle, we have the thalamus. So here we have the thalamic nuclei. So these are the basal ganglia, caudate, putamen, globus pallidus, and then we have the thalamus, and between this the white matter tract which is running. So anterior limb, genu, and posterior limb of internal capsule. Okay, so this is where you have internal capsule. Within the third ventricle only, can you see something very white? What is this? This is the pineal gland. Alright, so this is nothing but pineal gland calcification. So remember, this is pineal gland calcification, which is physiological, something that we'll see in a lot of normal population with age. So what is very important here is this hemorrhage within the putamen. So this is acute hemorrhage for you. So most common site overall for hemorrhage in the brain is putamen, and this is seen with hypertension. Very frequent one-liner question in fact of NEET. The most common site of hypertensive bleed, it's putamen. Okay, so remember the risk factor here is hypertensive patients, and the vessel which is involved is the same as lacunar stroke. Do you remember that? So this is the lenticulostriate branch of MCA, and this vessel is called as the Charcot's artery. And why this hemorrhage happens is because these small vessels will have these small microaneurysms. Okay, so these microaneurysms can rupture and result in bleeding. So these are called as Charcot-Bouchard microaneurysms. Okay, so these are referred to as Charcot-Bouchard microaneurysms, which can rupture and lead to hemorrhage. Okay, so this is about putamenal bleed in hypertensive patients. So now we talk about a cause of intracranial bleeding in young. So in elderly, we have seen how it's in the putamen, it's because of hypertension, whereas in young patients, the most common cause of intracranial bleeding is what is called as AVM. AVM stands for AV malformation. So what we see here is this large focus of acute hemorrhage inside the cortex. So this is what is intracranial hemorrhage. The most common cause in young patients, it's called AVM. So arteriovenous malformation is an abnormal communication between the arteries and veins via this dysplastic network of vessels that we call as nidus. So the hallmark of an AVM is the nidus, and when we do a CT angiography, you would see how between the large arteries and veins there is this abnormal network which is nidus. And just like we saw with SH, here as well the gold standard is going to be a digital subtraction angiography. On a DSA, when you put contrast inside the vessel, you can see how from the middle cerebral artery, so this is the ICA, this is ACA, and this is MCA. So in the MC, you can see how there is this cluster of vessels here which is draining into the veins, right? So you can see early filling of the veins, denoting that in the same arterial run, when you have the veins, it means that there is abnormal communication, and that is this cluster which is nidus. So what we have to do is we have to block this, we have to embolize this, and for embolism we will use agents like glue or coil. So we can put glue here in the nidus, or we can put coils which will stop the blood from going, and that is how AVMs are treated. So that is why DSA is the gold standard, because you can diagnose as well as treat this AVM via means of embolizing agents like glue or coil. Okay, so this is the management of AV malformations, arteriovenous malformations. And one extra point you can remember here is we use a grading system called Spätzler-Martin grading. Alright, so Spätzler-Martin grading is what is used for knowing the severity of AV malformation. Okay, so here you can possibly get a question on this DSA image, or you can get a theoretical question from this. One more vascular malformation, wherein we want to remember a sign called popcorn sign. Remember, we've done popcorn sign in breast imaging, wherein we saw fibroadenoma has a popcorn appearance on mammography. We also see this in respiratory system, where a hematoma has a popcorn sign. And this is the third popcorn that we have in radiology, wherein on the brain MRI you have this black lesion because it is bleeding. Yeah, so there is blood which is resulting in this loss of signal, and you can see some areas of hyper intensity. So this is an accumulation of blood which is a cavernoma. So cavernous angioma or a cavernoma is what is this. All right, so a popcorn sign is going to be seen in a cavernoma. The next malformation you have here is a pediatric malformation, wherein here, if they ever ask you this in an MCQ, the presentation is going to be so typical that you will not go wrong. So here they'll give you the history that there is a newborn infant who's having a high output cardiac failure, and in addition there is an intracranial bruit. So intracranial bruit here is your buzzword, and this is because of the presence of this giant vascular structure that you can see, which is the vein of Galen malformation. So the diagnosis here is vein of Galen malformation. So here this is also actually a type of a AV fistula. So this word vein of Galen malformation is actually a misnomer because it's not an AVM, it's actually a AV fistula. So AVM versus AV fistula, when you have a direct communication between an artery and a vein, that is a fistula. When you have artery and vein abnormally communicating via nidus, like we saw, that is malformation. So here actually there is a fistulous communication between the arteries and veins, and that results in a lot of blood going inside the vein of Galen. Yeah, and that is why it becomes very, very large. And in fact, it is not even the vein of Galen, it is the embryological precursor of vein of Galen which becomes enlarged, and that vessel actually is called as the medial prosencephalic vein. Okay, so why I've written it in very tiny letters is because it's not very important for you to remember, but just telling you for your information that it's not the vein of Galen, it's actually the medial prosencephalic vein which actually undergoes hypertrophy. So the clinical history is going to be enough to make a diagnosis. Imaging wise, they can give you ultrasound, CT or MRI. So here I am showing you a Doppler image, wherein you can see how in the center of the brain here you have this very large vessel which is the vein of Galen. On the MRI you can see this large flow void. We call this the flow void because vessels do not take up the signal on MRI, right? So you can see how this black serpentine structure is so enlarged on the sagittal image. Same you can see on the CT angiography image, you have this giant vein of Galen that is draining into the straight sinus. Okay, so this is what a vein of Galen would look like. Okay. Next, we have a malformation wherein on the DSA you can see how this is the ICA, and instead of seeing the proper branches of MCA and ACA above the clinoid part of ICA, that is supraclinoid ICA is narrowed and stenosed, and you have all of these tiny collateral vessels like a puff of smoke. So this is called as puff of smoke appearance that is seen in a disease called Moya disease. So this is seen in Moya disease, wherein you have supraclinoid ICA stenosis, and that is why you have these various collaterals which come and fill in and supply the brain, and this is one of the most important causes of pediatric stroke. Okay, so when you have a stroke in a child, one of the considerations is Moya disease. For the exam purpose, you want to remember it shows you the puff of smoke appearance. Okay, with this we finished the discussion on stroke and other vascular pathologies of the brain. Now we are going on to a brief discussion on brain tumors. This is something we'll also study in PATH, so I'd advise you to study it in integration, simultaneously, just be done with this topic. So overall, when we talk about brain and tumors, from our thumb rules, you know that anything to do with brain, particularly tumors, we talk about MRI. Throughout the body, tumors, infection, inflammation, we need to give contrast. So the investigation of choice is going to be contrast enhanced MRI or gadolinium MRI for brain tumors. Overall, most common brain tumor, like always, Metastasis or secondaries is overall the more common tumor. When we talk about primary brain tumor, most common benign in children, it is pilocytic astrocytoma. So this is a grade 1 tumor, occurs in the cerebellum, and here you would have a cyst with a mural nodule. If you remember in GU system, I had told you anytime we have a cyst with mural nodule in the cerebellum, if it is a child, we talk about pilocytic astrocytoma. If it's an adult, we talk about hemangioblastomas, right? So this is pilocytic astrocytoma. I am also drawing the pattern so that you have that mental picture. It's going to be cyst with mural nodule in the cerebellum. When we talk about the most common malignant brain tumor in children, it is medulloblastoma, which is also going to be occurring in the fourth ventricle. It's a very vascular tumor, WHO grade 4 tumor, and this is also in the fourth ventricle. So both of these, in fact, overall in children, the more common brain tumors are infratentorial, below the tentorium cerebelli. All right. On the other hand, in adults, most common benign brain tumor is meningioma, whereas in adults, the most common malignant brain tumor is GBM, or now called as glioblastoma, right? So previously we used to say glioblastoma multiforme, now we say glioblastoma, okay? So these are the 4 tumors which are the most common. So now let's look at the adult tumors first. What we are looking at in the first image, which is a contrast enhanced MRI, is along the dura. There is this tumor which is showing a lot of enhancement and has this tail, yeah. So the typical feature is this tail that is called as the dural tail sign. So this is a hypervascular mass with a dural tail sign. Pathologically, what you're going to be seeing here is the presence of psammoma bodies. What I'm talking about is the most common benign tumor in adults, that is meningioma. Okay, so remember, meningioma seen in young females. Additional point for you here, they have progesterone receptors, and that is why it increases in size in pregnancy. Okay, so this is meningioma. On the other hand, when you look at this tumor which is crossing over onto the other side, very few tumors can do this, which is crossing over on the other side and invading the 2 lobes. All right, so when a tumor crosses the midline, this is like a butterfly, yeah. So this is called as a butterfly glioma, and the diagnosis here is glioblastoma multiforme, very poor prognosis, grade 4 WHO tumor, and you can see how it's showing so much necrosis, no areas of enhancement in the center because of necrosis. The pathological counterpart here, you would see how there is this central serpentine necrosis. If you look at the pathological specimen, there would be serpentine necrosis, and there would be this pseudo palisading appearance that would be noted. Okay, so this is what you need to remember as far as rad-path features of these 2 adult tumors are concerned. When we talk about the pediatric most common tumors, in the first image you can see how in the cerebellum, in the T2 image, there is water. So this is a cyst, and within the cyst you can see that there is a nodule. On giving contrast, this nodule is showing enhancement, but the cyst, because of water, will not show any enhancement. So this pattern is called as cyst with mural nodule, and the diagnosis becomes pilocytic astrocytoma, a grade 1 tumor. Pathologically here you're going to see the presence of Rosenthal fibers. Okay, so that is the histopathological manifestation. One differential, if such an appearance is seen in an adult, we take into consideration a hemangioblastoma, and you want to rule out VHL, von Hippel-Lindau syndrome. Okay, so pilocytic astrocytoma is a grade 1 tumor, good prognosis. And the worst prognosis in pediatric population, a very hypercellular tumor in the fourth ventricle. This is medulloblastoma. So this is something which has been asked as an image-based question, wherein they've put in an arrow here and asked where is this tumor located. So actually an anatomy question that it is in fourth ventricle. Okay, But you want to know that this is a WHO grade 4 tumor with a poor prognosis, and it can actually have drop metastasis. Okay, so it can have metastasis into the spine, coating the spinal cord. Pathologically, here you would see the pseudo rosettes with central neuropil. So whenever the center is not empty, we call them pseudo rosettes. So these are Homer right pseudo rosettes. Okay, so Homer right pseudo rosettes is what we can see in medulloblastoma. Okay, very important, something that has been asked a lot of times in the NEET exam is what we are seeing here. So here you want to remember all C's. So it's a child who's having a tumor which is calcified, a tumor which is cystic, and the name also is with C, so it is craniopharyngioma. So remember that a craniopharyngioma is a pediatric tumor which is cystic with calcification, and it actually has this very thick machine oil kind of fluid. All right, so it is cystic, but it has this thick machine oil kind of fluid that the pathologist will also teach you, and along with this you have wet keratin which is present pathologically. Okay, and wherever we have keratin, just an extra edge point for you, remember radiologically on T1 you are going to have hyperintensity. So there is also a tumor which will be T1 hyperintense. You've seen very few things are T1 hyperintense. Just to recapitulate, you have melanin, you have posterior pituitary, gadolinium, keratin, which all appear T1 hyperintense. So this is one of the rarer tumors which would be hyperintense on T1. Okay, so here you can see how there is a tumor in the suprasellar location. So this is located above the sella. So if this is the sella, it is seen somewhere around this place, and this is the location of the optic chiasma. So this is where you have the optic chiasma which gets compressed, and that is why the typical history that they'll give you in this child is of optic chiasma compression, that is bitemporal hemianopia. So that is the description that would be mentioned because of chiasma compression where both the nasal fibers cross. So you have bitemporal hemianopia, right? So there is a suprasellar tumor with calcification, and on the axial section you can see how there is this black cyst with this white calcification here. Okay, so this is what we want to remember about craniopharyngioma. Pathologically, there are actually two types, and all of these features are seen in the type that is adamantinomatous type. Okay, the other type, which is papillary serous, is what is seen in adult population, but it will not have these typical features. So for the exam purpose, this is what you want to remember. If we see a large pituitary lesion in an adult patient, so what is this? You can see how it has this figure of 8 or snowman appearance. It is arising from the sella and going into the suprasellar compartment. You can see these two ICA flow voids on two sides of the lesion. This is a pituitary adenoma. What adenoma? Micro or macro? Obviously, such a large lesion more than 1 centimeter is a macroadenoma. So this is a pituitary macroadenoma which has this figure of 8, also called as a snowman appearance. When it goes from the sella into the suprasellar aspect, it has this constriction and hence the shape. Okay, so this is a macroadenoma. A tumor which we also study in ENT is what we are looking at here at the CP angle. What is the CP angle? So this is the angle between the pons and the cerebellum. So the cerebellopontine angle, you have a tumor shaped like an ice cream cone. Yeah, so you can see that there is a larger diameter of the tumor, and then it tapers when it goes into the internal auditory canal. So this is a vestibular schwannoma. So a vestibular or an acoustic schwannoma is what you are seeing here. So this is a tumor that arises from the 8th cranial nerve, particularly the inferior vestibular part of the 8th cranial nerve is the most common site, and this has this ice cream cone appearance because at the CP angle it has this larger part, and when it goes into the internal auditory meatus it tapers. Okay, so this is very, very important. And pathologically even more important, you have these two areas. One is the cellular area called the antony A area, and the acellular area called the antony B area. The cellular area would have verrucate bodies, all right. So this is the integration of schwannomas. Okay, another place, just to correlate with you, another place where we see the ice cream cone appearance is in the middle ear. So in the middle ear, the normal ossicles, that is the malleus and the incus, will have this appearance, all right. So the ossicles, which is malleus and incus, would have this ice cream cone appearance on the CT. So this is a high resolution CT of the temporal bone. These are all mastoid hair cells, and this is the middle ear with this white ice cream cone that you can see, which represents the malleus and incus. Okay, so now with this we move on to the next topic, which is CNS infections. Okay, so first you want to remember that for CNS infections, again the investigation of choice is a contrast enhanced MRI. Okay, so contrast enhanced MRI, particularly when we deal with encephalitis and abscess. Investigation of choice is CMR. For meningitis, we all know that investigation of choice is lumbar puncture and its evaluation of the CSF. But for encephalitis and abscess, the investigation of choice is again contrast enhanced MRI. So the first thing which I want to show you here is a well-defined round lesion. When we give contrast, what does it show? It shows you this peripheral enhancement. This is what we like to call as ring enhancing lesion. So there is a large well-defined ring enhancing lesion. And what is this image? Where you don't see the skull, you don't see the fat. This is DWI. And on diffusion weighted imaging, what do you see? It is white, meaning it is showing you diffusion restriction. So when you see such an image, whether it's CT or MRI, when it shows you this thick rim of enhancement with diffusion restriction, this is an abscess. So this is a cerebral abscess that we are dealing with. Okay, a lot of times it is associated with sinusitis. It's a complication of sinusitis or mastoiditis, and such a history might be given to you. Okay, so this is a cerebral abscess. Now the images that we have here, in the first image you can see it looks somewhat like the star of death appearance I had shown you for SH. Yeah, so in SH, in the basilar cisterns, we had hemorrhage, and that is why it was appearing white on CT. Now we have done a contrast enhanced MRI, and you can see how there is so much enhancement here. It is because you have basilar exudates. So now in the basilar cisterns, we have this thick pus which has accumulated, and this is a feature of TB. So what I am showing you here is TB meningitis, all right. So TB meningitis, remember, you have these thick basilar exudates which can result in a few complications. What are the complications? One, it can lead to the narrowing and vasculitis of the circle of Willis vessels, and that can lead to infarcts, right? So it can lead to vasculitis because of inflammation, because this is where circle of Willis lies. And the other complication is it can obstruct the flow of CSF and result in hydrocephalus. So this that I have written for you here is the triad of TB meningitis, which is hydrocephalus, vasculitis and basilar exudates. So TB meningitis is far more common, but you can also have parenchymal lesions which are called as tuberculomas. So these tuberculomas are these foci of necrosis which are also going to show ring enhancement. So there are these ring enhancing lesions, can you see? And they have the feature that they are more common around the brainstem, and the typical manifestation is that they are going to show this conglomeration. Can you see how they are all merging with one another? Yeah, so when you see ring enhancing lesions, small lesions around the brainstem showing conglomeration, it's more likely to be TB. And we have a tool called MR spectroscopy that can show you this peak. Can you see how there is a lipid peak here? Yeah, so MR spectroscopy is going to show you a lipid lactate peak which represents necrosis. Okay, so that is again a supportive finding of TB. So TB meningitis, you'll have basilar exudates resulting in obstruction of flow, and you can have vasculitis. When we have parenchymal lesions called tuberculomas, they're around the brainstem with conglomeration and show a lipid lactate peak. You need to distinguish these ring enhancing lesions from TB, and the disease that we are talking about is NCC, which is neurocysticercosis. So as the name suggests, there are going to be cysts in the brain, cercosis meaning there is larva. So this is a parasitic infection which occurs because of Taenia solium. So Taenia solium eggs ingestion can lead to neurocysticercosis, wherein you will have presence of these vesicles in the brain with a central scolex. So the hallmark here is the presence of multifocal lesions that you can see, and they have this progression of 4 stages. So this staging system that you are seeing here is called the Escobar staging. So along with the staging, I'm going to show you the radiological appearance as well. Okay, so in the vesicular stage, you're going to have these fluid filled lesions throughout the brain. So you can see this is a T2 weighted MR because the ventricles are white. Yeah, water is white. So you can see that there are so many fluid filled lesions with a central scolex. Okay, so in the first stage, we do not have the inflammatory activity which has started as yet. So here, if we do give contrast, is there going to be any enhancement? No, there is no enhancement. Are there going to be any clinical features? No clinical features yet. Okay, but in the next stage, when it becomes colloid vesicular, now the inflammation is starting and you have edema around it, right? So now you can see that there is presence of edema around the lesions. Now there's going to be definite enhancement. Now there are going to be symptoms in the form of seizures in the patient, right? Further, when it progresses, you will have a granular nodular stage. This is when now it's starting to heal. Okay, so here you will start to have spotty calcification. Remember, calcification is a sign of healing, but you also have activity. So enhancement is going to be seen, like you can see in this image. This is the post contrast image. You can see so many ring enhancing lesions, right? So this here you will have contrast and you will definitely have clinical manifestations. And finally, in the last stage, which is the end stage, that is the nodular calcified stage, wherein all the lesions are now dead, they are all calcified, so no contrast, and again, because now it is healed, you will have no clinical manifestation. Okay, so this multifocality gives rise to this appearance called as starry sky appearance. Alright, so just a path integration, we also see the starry sky appearance when we talk about Burkitt's lymphoma, right? So this is one more place, that is neurocysticercosis, that shows you starry sky appearance. Okay, so Escobar staging, NCC, Taenia solium. The 4 stages being vesicle, where you have cyst with scolex, colloid vesicular, granular nodular, and then nodular calcified. Not very important for you to remember complete names and everything, but you just want to know the evolution as a concept. Okay, otherwise they'll just give you one of these images and ask you diagnosis. And the trick is to see a cyst. You will see a cyst with a central scolex. Okay. Next infection that we're going to talk about is a pediatric infection, more commonly, wherein they'll give you a typical history that the patient is having fever with behavioral abnormalities, and that is because the areas which are involved are part of the limbic system, including the frontal and the temporal lobes. So this is an encephalitis that favors the involvement of frontal temporal lobe. Like you can see how the cingulate gyrus, the medial temporal lobe, the hippocampus is getting hyper intense, and that is what is involved here. And what I am talking about is herpes simplex encephalitis. So this is HSV encephalitis, and HSV1 is the more common agent to be implicated here. Okay, One more special feature of HSV encephalitis is the fact that there can be hemorrhage here. So there's the hemorrhagic encephalitis. So you can have associated xanthochromia when you do a CSF tap, or you can see presence of RBCs. And on imaging, if you do a susceptibility weighted imaging, remember that we saw for diffuse axonal injury, there also we were picking microbleeds. So here also on susceptibility weighted imaging, we can actually pick up microbleeds because this is a hemorrhagic encephalitis. Okay, so these are the salient features of HSV. You can diagnose it on the basis of the sites which are involved. You will have hyperintensity and swelling, edema of the cortex here. Okay, so this is HSV. Now, particularly in HIV/AIDS, what are the three special opportunistic infections in the brain that we need to know? So the first one, you can see how bilateral basal ganglia. In fact, I'm going to teach you two infections involving bilateral basal ganglia. In the first one, understand the pattern. In the first one, both the basal ganglia on a T2 weighted image are showing you this soap bubble appearance. There are these multifocal cysts giving rise to this white soap bubble appearance, and the diagnosis becomes cryptococoma. So these are parenchymal cryptococcal lesions. If you have been given a post-contrast image wherein they are showing you these ring-enhancing target lesions where there is peripheral and eccentric central enhancement, this is called as a target lesion, and the diagnosis is the most common space-occupying lesion in the brain in HIV, toxoplasmosis. Yeah, so overall this is the most common infection that we have. And the third one, where you have asymmetrical white matter involvement. Yeah, so you can see how white matter is involved here and it is asymmetrical. This is PML, progressive multifocal leukoencephalopathy, and this is because of JC virus. We know PML is also a side effect with a drug for multiple sclerosis, which is natalizumab. Okay, so in HIV it is infective. So these are three patterns for HIV/AIDS. If they have to ask something, it would be toxo. Okay, so this is about infections in HIV/AIDS. So now we want to talk about the most important skull x-rays. Alright, so in every exam invariably, you get one of these x-rays, and we need to understand the pattern approach to distinguish them, otherwise you'll get confused. Okay, so I'm going to show you all of the x-rays compiled in one place. Okay, so the first image that we are seeing is the skull x-ray, and you can see how there are these black lytic lesions. So this is what we call as lytic lesions. Normally the bone is supposed to be white. When you see these black lesions, it means bone has been eaten up, it's been eroded. Okay, so this lytic lesion, now see the shape, it's very tiny. Yeah, so this has been likened to the term salt and pepper. So when you have this very tiny lytic lesions, this is called as the salt and pepper appearance, and this is a finding that we see in hyperparathyroidism. So this is a feature of hyper PTH, hyperparathyroidism. And here you want to remember one additional point. We'll also talk about this in nuclear medicine, but then when we talk about primary hyper PTH, the most common cause is a parathyroid adenoma, and the investigation of choice for this is a SESTA-MEB scan. Okay, so this is a nuclear medicine scan, but because it is so important, I'm just trying to revise it for you right here. Okay, so salt and pepper sign is hyper PTH. We know that parathyroid hormone is responsible for bony resorption. Yeah, it causes an increase in calcium and decrease in phosphate. So it basically causes bony erosion, and because of this bony resorption, we are having these tiny lytic lesions like salt and pepper. Okay, the next approach is when we have these lytic lesions, but they are much larger than the salt and pepper. Yeah, so this is called as a raindrop skull, or something which is called as a punched out skull. It looks as if we have done punches in the skull. Yeah, so this is a raindrop appearance or a punched out skull appearance, and this is what we see in multiple myeloma. So multiple myeloma is going to have these multifocal lytic lesions. In fact, in path we've studied that multiple myeloma will have the crab manifestation. So you'll have hypercalcemia, renal failure, anemia, which is of chronic disease, and bony lesions, right? So these are the bony lesions, which are these multifocal lytic lesions. And in fact, the other differential that we have for such an appearance is lytic metastasis. So diffuse lytic mets can also have this raindrop appearance. Okay, so raindrop or punched out skull, multiple myeloma predominantly. If that is not there in the options, the other answer is lytic metastasis. The next one, wherein you will have the history of a child. So first, it's a child, unlike the first two when it would be an adult. So salt and pepper punched out, usually adults. When you have a child and you are seeing that there is a large lytic lesion, what kind of a lesion? This is called as a geographical, so large that we can draw it like geography. So geographical lytic lesions, and look at the margins I've drawn. You can see the inner and outer table separately. Yeah, so such a margin is called a beveled margin. So a child with much larger lytic lesions now, which are geographical lesions with beveled margins, the diagnosis is LCH, which stands for Langerhans cell histiocytosis. Okay, so this is going to be seen in LCH, which is a multisystemic disorder. You can have liver involvement, skin involvement, you can have multifocal bony lesions. Yeah, so you can have skull lesions, spine lesions, pelvic lesions. So diffuse systemic bony lesions can be associated. And an important point that we study in path here is the presence of these tennis racket shaped Birbeck granules that can be seen on electron microscopy. Okay, so this is LCH, geographical lesions with beveled margins. In fact, if this pathology, if there's a solitary lytic lesion in the brain, that is what we call as eosinophilic granuloma. Okay, so eosinophilic granuloma is the name of the pathology that we say when we have a solitary involvement of the skull. Okay, very important for the FMG exam. There used to be a question on this almost always before a few years. What we see here is this hair on end or a crew cut appearance. We can see how the bony trabeculae here are so expanded. So this is called as a hair on end or a crew cut appearance, and this is what we see in any hemolytic anemia. So this is the appearance in hemolytic anemia. So the differentials could be either sickle cell anemia or thalassemia, depending on the options. So usually it is thalassemia that is tested. In association clinically, you would see chipmunk phases. Yeah, so chipmunk phases is something that could also be described to you because of, again, extramedullary hematopoiesis. Fine. So this is the hair on end or crew cut appearance. The next skull X-ray that we have here is where you have this calcification, and the orientation of this calcification is like a tram track. So this is called as the tram track skull or tram track calcification, which is seen in the neurocutaneous syndrome, that is Sturge-Weber. It is the only neurocutaneous syndrome which is sporadic. Remember, all of the other neurocutaneous, neurofibromatosis, tuberous sclerosis, VHL, they're all autosomal dominant. Okay, so Sturge-Weber, one, it's sporadic and it shows a triad of findings. One, you will see that there's a facial nevus, which is called as a portwine stain. It is frequently along the trigeminal territory, and the most common is V1, right, along the ophthalmic nerve territory. The other part is you can have congenital glaucoma here, and you will have refractory seizures because of unilateral cortical atrophy, which undergoes calcification. So one hemisphere is atrophied and completely calcified. That is why you have this calcification. So there is gyral calcification. The gyri shows calcification, and that is why this tram track orientation. Okay, so this is Sturge-Weber syndrome. Next skull that we have here is which is showing you these convolutions. Yeah, so this is like a copper beaten or a silver beaten utensil. So this is the copper beaten appearance that is seen with raised intracranial pressure. So anytime in a child you have raised ICP, the skull would have this appearance of a copper beaten skull. And you also want to remember here what are the earliest skull X-ray changes. Yeah, earliest skull X-ray changes in a child. So in a child, what we'll have, because the sutures are not yet fused, the sutures are going to be opening up, they're going to be widening because of the raised ICP, and that is what we call as sutural diastasis. So there is sutural diastasis in a child, and in an adult what we are going to be actually seeing is the erosion of the sella. Because the sutures are fused, now the pressure is going to come down to the sella, and we will see that the dorsum sella, the posterior wall of the sella, undergoes erosion. So earliest sign in an adult is a dorsum sella erosion. Okay, so these were the important skull X-rays. Right, so what all did we see? Quick recap: salt and pepper skull for hyperparathyroidism, punched out skull or raindrop skull for multiple myeloma. A large geographical lesion was LCH in a child. Then we talked about tram tract calcification, which is Sturge-Weber. We saw hair on end appearance for thalassemia, and we saw a copper beaten appearance that was raised ICP. Okay, now we want to look at a few important signs and a few important pathologies very quickly, which are asked as a standalone question. Okay, so the first one is in integration with medicine, wherein they'll give you the history of a young female who's having symptoms which are disseminated in time and space. When I say this, straight away a bell goes in your mind, ma'am is talking about multiple sclerosis. Yeah, so multiple sclerosis, MS, is a demyelinating disorder wherein you're gonna have different parts of the brain and spine which get involved at different times. This most common type of MS is what is called as relapsing remitting type of multiple sclerosis, and this criteria is called as the McDonald's criteria, which is the dissemination in time and space. Means you will have different types of symptoms, right? So you can have vision loss, you can have sensory abnormalities, which are associated. There are other signs such as the Lermit sign, which is a shock-like sensation down the spine. You can have Uthoff's phenomenon, where the symptoms worsen with a hot shower. Yeah, so such supportive evidences can be given, and then they can show you the imaging. So this is a flare sequence wherein we have suppressed the CSF in the ventricles so that these periventricular hyperintensities can be noted. So you can see how there are these periventricular demyelinations that are seen as hyperintensities, and this has been given the name of Dawson fingers. Okay, so this is what is called as Dawson fingers, and this is one of the preferred sites of demyelination, that is the periventricular white matter. Apart from that, you can also have optic neuritis in MS, and remember, optic neuritis in MS is usually asymmetrical. Yeah, and the investigation of choice to identify it is CE-MRI, contrast enhanced MRI, wherein you would see enhancement in the inflamed nerve. Okay, so overall, when asked investigation of choice for MS, it is always CE-MRI, because that also tells you about the activity. When the demyelinating lesions are active, they'll show inflammation and enhancement. Okay, so that is what you want to remember about MS in general. One more pointer about MS, as far as the spine is concerned, you want to remember that there is short segment. Yeah, so there is short segment involvement of spine, wherein less than 3 vertebral columns is going to be involved, and even on a cross section you will see how it is very limited patchy involvement. Okay, so short segment patchy involvement in the spinal cord is what will be seen in MS versus transverse myelitis. So when we talk about transverse myelitis, it's going to be longitudinally extensive, meaning more than 3 vertebral segments would be involved. Okay, so that is transverse myelitis. So next we are going to be discussing a very important pediatric malformation that is called Dandy-Walker malformation. Okay, so what are the features of Dandy-Walker? You should be able to diagnose this on an ultrasound or an MRI. Alright, so it's very simple. What you want to remember is anytime you see that the posterior fossa is enlarged and there is a cyst. Can you see how on the MRI this is very white, right? So this is because it is filled with fluid. So Dandy-Walker malformation, remember, has an enlarged posterior fossa. So first, the posterior fossa is enlarged. Second, you have a posterior fossa fluid collection, which is a cyst, and you have very important cerebellar vermis agenesis. So the vermis of the cerebellum is not well formed. That is why the fourth ventricle, you can see how behind the pons, this is the fourth ventricle. The fourth ventricle communicates with this posterior fossa cyst. Okay, so these are the features of Dandy-Walker: enlargement of posterior fossa. You can see how large it is. There is a fluid collection and there is vermian agenesis. And one more sign of the posterior fossa enlargement is the fact that the confluence of sinus is pushed up. So the confluence of sinus is called as torcula herophili, torcula, and the torcula is pushed up here. Alright, so when there is pushing up of the torcula, that suggests that there is enlargement of the posterior fossa. So this is what you want to remember about the findings of Dandy-Walker malformation. The next sign that we want to talk about is when you have the lateral ventricles being enlarged. So this is a coronal image wherein you can see how the lateral ventricles have this large box car orientation. So this is the box car shape of the lateral ventricles, and this is something which is seen when you have caudate atrophy. You can see how the caudate nucleus is very much atrophied. And what is this condition wherein you have caudate atrophy? We are talking about Huntington's chorea. So Huntington's disease or Huntington's chorea, remember, is a trinucleotide repeat. Yes, you want to remember the mnemonic: hunter is in a cage. So this is a CAG repeat. You want to remember there's a hunter in the cage. How many walls does a cage have? 4, right? So this is seen in chromosome 4, and from CAG itself you can remember all of these three undergo decrease. So caudate atrophy, biochemically acetylcholine and GABA levels undergo a reduction in Huntington's chorea. Okay, so you want to remember, because of caudate atrophy, the lateral ventricles enlarge, having this boxcar shape. 3 signs for you, 3 images for you. In the first image, you can see how one of the most important structures, you can see some of it here normally, which is the corpus callosum, is not there, and because the corpus callosum is absent here, you have the gyri and the sulci all falling onto the ventricles here. So this is the third ventricle on which everything is falling upon. So remember, this is what is showing you a corpus callosum agenesis. This is associated with various syndromes. One of the more important ones is Aicardi syndrome, which will have corpus callosum agenesis. The next image is showing you that the midbrain here, the ventral part of midbrain is atrophied, and this looks like the hummingbird. Alright, so this looks like the beak of a hummingbird. So this is what is described as the hummingbird sign, and this is seen in a condition called progressive supranuclear palsy, PSNP, progressive supranuclear palsy. This is a type of Parkinson plus syndrome where the patient has frequent falls and ataxia. Okay, so normally you can see how it is this thick midbrain orientation. Here it's very tapered anteriorly. Okay, the next one where the pons are showing you this hyperintensity, this cruciate hyperintensity, this is called as the hot cross bun sign, which is seen in MSA, multisystem atrophy of the C type, of the cerebellar type, and this is also Parkinson plus syndrome. Okay, so all of these signs not very important nowadays. You don't get one-liner questions based on these signs, but just for completion sakes, I'm just showing you these appearances here. The next image you can see, we are at the level of the midbrain. Yeah, so this is the midbrain, wherein you can see how there is hyper intensity, and this looks like the face of a panda. It really does. Yeah, so this is face of a panda sign, which is seen in Wilson's disease. Okay, so they'll give you some sort of history here about having Kayser-Fleischer rings, liver dysfunction, neuropsychiatric manifestation, dystonia, such manifestation would be given, and this MRI appearance wherein you see hyperintensity in the midbrain. This is face of panda sign. Next is very important in integration with medicine, wherein they can give you that there was a patient who's having hyponatremia, and because of sudden overcorrection, you know that we need to correct hyponatremia slowly if there is overcorrection. In fact, we need to correct it around 8 milliequivalents per day. If there is over aggressive correction, what can result is osmotic demyelination syndrome. So there can be demyelination. This was earlier called as central pontine myelinolysis. Now this is called as ODS, osmotic demyelination syndrome, and you have the central pons most commonly affected here. You can see this hyperintensity in the central pons, and this has been described as the trident sign, or some people also like to call it the piglet sign. Some people with great imagination thought that these are the eyes of the pig and this is the snout or the nose of the pig, and gave this the name piglet sign or trident sign. But the important part is that the central pons have hyper intensity here. Okay, so this is because of osmotic demyelination. This history would always be provided about rapid overcorrection of sodium. Okay, the next one, where the midbrain looks like a molar tooth. Yeah, so this is the molar tooth appearance, which is seen in a malformation called Schubert syndrome. So just the name is enough. Schubert syndrome, you have molar tooth appearance. Next, we have two tigers who come into play. So in the first one, this is a repeat aims question. You have a tigroid appearance of white matter. So white matter looks like a tiger, the stripes here, and this is because of a white matter leukodystrophy. So you have a white matter disorder, and when the veins are spared because of perivenular sparing, you have these stripes here. So this is something that we see in MLD, that is metachromatic leukodystrophy. In biochemistry, you must have read that there is a deficiency of aryl sulfatase here. So aryl sulfatase is deficient. This is MLD, metachromatic leukodystrophy. There's another syndrome called Pezelius-Merzbacher. Don't even go into the full form. Remember PMD, Pezelius-Merzbacher. These are two diseases with a tigroid appearance. The important one is MLD. Not to be confused with the eye of the tiger sign. So eye of the tiger sign also an Ames question. So Ames is definitely fond of tigers. Yeah. So eye of the tiger sign is when in the globus pallidus. Remember the anatomy? Here this is the lentiform nucleus. So you have the outer putamen and inner globus pallidus. Within the globus pallidus, can you see how there is hypointensity and then there is central hyperintensity, which does look like the eye of the tiger? This is because of iron accumulation. So there is iron accumulation in the globus pallidus, and this is seen in a disease called pantothenate kinase associated neurodegeneration. So this is pantothenate kinase associated neurodegeneration, which was previously called as Halle-Warden spots disease. Okay, so since then Ames has also stopped asking such questions. It's a very old question, back when I was preparing around 2014, this was a repeat question. So nowadays you don't really get such crazy questions. Okay, so this is pantothenate kinase associated neurodegeneration. Three pediatric malformations, these are called as neuronal migration defects, wherein the neuronal migration doesn't happen well and you have abnormalities of cortical sulcations and gyrations. So what you see here is a completely smooth brain. Can you see how there are no gyri and sulci? And this is what is called as lissencephaly. Okay, so this is called as lissencephaly, and brain has a very smooth figure of 8 appearance. So figure of 8, third place where we see this. First is what we have seen in this lecture itself, pituitary adenoma. Second is lissencephaly, and third is what we will study in cardiovascular system in TAPVC, totally anomalous pulmonary venous communication. Okay, so this is lissencephaly where you have absent gyri and sulci. Next, where you have a cleft. Can you see how there is a cleft wherein the ventricles are communicating with the subarachnoid space? This is what is called as schizencephaly. So schizencephaly is where you have this cleft or this defect through which the CSF is herniating, and this is a malformation wherein both the sides are fused. So you can see that there is a single monoventricle that you are seeing. The thalami are both fused with one another. So this is holoprosencephaly, a fused brain, but is also called as pancake brain, that fused like a pancake. We've also seen pancake kidneys wherein the two kidneys are fused. This is holoprosencephaly, and this is associated with trisomy 13, that is Patau syndrome. Okay, so this is holoprosencephaly. So this is about the neuroradiology aspect. Very quickly I want to touch upon two areas. One is the orbital pathologies, and then we want to talk about PNS, which will also have an overlap with ENT. Okay, so two orbital or optic nerve tumors that I want to contrast here. In the first one, first of all, for both of them, investigation of choice again remains CE-MRI. So remember, as a general rule, anything in the central peripheral nervous system, whenever we have a tumor, it's always going to be MRI, which is contrast enhanced. Okay, so both of these are CMR images. In the first one, look at the left optic nerve. It is having this fusiform enlargement with enhancement. So this is what is the appearance of an optic nerve glioma. So an optic nerve glioma will have this diffuse fusiform appearance, and the nerve will not be seen separately. Okay, so this is what it appears like. On the other hand, the other one, you are having the optic nerve seen separately. So this is again the left side. You are having this tumor encasing the nerve on both the sides. So this is an optic nerve meningioma, and this is called as the tram track appearance. Again, lots of places where we see tram track, isn't it? Let's recall all of them. One is in bronchiectasis. We'll study this in respiratory system next. So bronchiectasis, we have seen this in Sturge-Weber syndrome. We also see this in ankylosing spondylitis. You have a tram track appearance. So 4 places right here in radiology itself. In PATH, we studied tram track in MPGN, membranoproliferative glomerulonephritis type 1. We see tram track. Yeah, so these are all the places of tram track. Even in Haemophilus ducreyi, you know, school of fish and tram track are associated. Okay, so this is about tram track. Now coming back, so here the optic nerve is seen separately, and you have this sort of an appearance which is encasing the tumor. So this is optic nerve meningioma. So these are two tumors of optic nerve. In this case, what you can see are the muscles, the extraocular muscles. In fact, in one of the FMG exams, you are asked to identify the structures of which. So this that goes through the center of the orbit is the optic nerve. Yeah, on the two sides we have the recti muscle. So medially, obviously medial rectus, laterally this is the lateral rectus. So you can see how the muscles are enlarged, and this enlargement is in the form of a Coca-Cola bottle. So this is likened to a Coca-Cola bottle when the muscle belly enlarges but the tendinous insertions are spared. Okay, so this is what is seen in thyroid ophthalmopathy. Okay, so in thyroid eye disease you would have the enlargement of extraocular muscles, and this is the Coca-Cola sign or the Coca-Cola bottle appearance, and the order is also something that you can remember. You can remember the mnemonic I am slow. So it is going to be inferior rectus, medial rectus, superior rectus, lateral rectus, and then the obliques are the last to be affected. So they'll ask you the first muscle, that is inferior rectus. Okay, so this is thyroid ophthalmopathy. Next is an image which has been asked very frequently from trauma. What you see here is a defect in the floor of the left orbit. There is an orbital floor fracture called as a blowout fracture. So this is called as a blowout fracture, also called as a trap door fracture or a teardrop fracture. Yeah, so here this is happening because of blunt trauma to the eye. When somebody gives you this knock into the eye, the floor gives way and you have the herniation of fat, and sometimes you will also have inferior rectus which can get entrapped in. That is why it is called as trapdoor fracture. All right, so this is your blowout fracture. With this we go on and discuss PNS. So the paranasal sinuses, you want to remember, investigation of choice is a high resolution CT. It has bone, it has air, two things best seen on CT, and because the anatomy is so intricate, we do a high resolution CT here. But the gold standard is FES. So functional endoscopic sinus surgery is the gold standard because it is diagnostic as well as therapeutic, right? Now a few pointers that you want to remember here about the anatomy. So you do get integrated anatomy radiology questions here. So I've just compiled all of the names of the ethmoidal cells and then we shall be looking at them. That is where you get a lot of questions from. So the largest ethmoidal air cell that we have is bulla ethmoidalis. Okay, so bulla ethmoidalis is the largest ethmoidal air cell that we have, and in fact it forms a part of the osteomeatal unit. The anterior-most cell, which we can also remember from Hindi as Aage, yeah, the name itself tells you I'm Aage. So agar nasal cell are your anterior-most ethmoidal cell. Posterior most, which is in relation to the optic nerve, so ON for Onodi cell. Yeah, so Onodi cell tells you that there is risk of optic nerve compression because it is the posterior most ethmoidal cell. Infraorbital cell is called as Haller cell, and a pneumatized middle turbinate is called as a concha bullosa. So the first part is to get oriented and acquainted to these names, and then comes the identification. So bulla ethmoidalis, largest. Aage, agar nasal, onodi, posterior. Infra is Haller, and pneumatized middle turbinate. When the middle turbinate also has air, that is called concha bullosa. So now we are going to be looking at all of them. First, I want you to get oriented to this image. This is the HRCT coronal image. So this is the plane that we most frequently used for the paranasal sinuses. Okay. So here you can see how these are the two maxillary sinuses. This is the orbit, so right and left orbit, and you can see these are the inferior turbinates, middle turbinate, and then you have the superior turbinates, and you can see this plate of bone which is the crista galli. So this is the crista galli, and on two sides we would have the cribriform plate. Okay, so this is grossly the anatomy. First of all, what are you seeing? The middle turbinates are pneumatized. So what do I call that? I call it concha bullosa. Now let's focus our attention here, which is the osteomeatal unit. So when we are looking here, this part where the maxillary sinus ostium is forming, this is the ostium. Okay, so this is the maxillary sinus ostium. Then you can see this piece of bone attaching to the inferior turbinate. What is this? This is the uncinate process. Okay, so U for uncinate. This cell here, which is the largest ethmoidal air cell, is bulla ethmoidalis. So 3 pointers we already have. We have ostium, uncinate, bulla ethmoidalis, which are part of the osteomeatal unit. This opens into this two-dimensional space. This is called as infundibulum, which further opens into this 3D space, which is hiatus semilunaris. Okay, so this actually tells you about all of the parts of osteomeatal unit: ostium, uncinate, infundibulum, hiatus, and bulla ethmoidalis. Okay, so when you read it in anatomy as a list, I remember when I was preparing, I just memorized this list. But now when you see this, all right, then it becomes so much more easier to remember what are the parts when you put an image to it. So that's how anatomy is to be read, by images. If you just memorize, it's not going to be helpful at all. Okay, so here, just to document it further, osteomeatal unit, what are the components? So you have the ostium of the maxillary sinus, you have the uncinate process, you have the bulla ethmoidalis, you have infundibulum, and you have the hiatus semilunaris, right? So these are the 5 parts that we have now gotten oriented to. So this is how you recognize bulla ethmoidalis. Now, if we have cut a plane much anteriorly, how do I know it's anterior? When maxillary sinus looks so small, yeah, and you have this air cell which is anterior, corresponding like bulla ethmoidalis, but we are cutting much more anteriorly. This is the agar nasal cell. When you see this cell which is below the orbit, that is the Haller cell. And when you see a plane where you can see these sphenoid sinuses, so these are the 2 sphenoid sinuses, and then there is this cell here, so this has to be posterior most. So this is Onodi cell, and why it impinges on optic nerve is because this is where you have the optic nerve, right? So when this enlarges, this can definitely go and obstruct and block the optic nerve, and this is how you can remember Onodi cell. Okay, so we have seen all of the cells that we had talked about. Very quickly, a few important pathologies wherein you do get questions from imaging. So this is a CT scan of the paranasal sinus, where you can see that the left side, everything is opacified, and you have the presence of this double density. You can see some hyperdense linear structures also. So this is what is AFS, allergic fungal sinusitis. So you want to remember this appearance of a double density sign, these white hyphae, double density sign seen in allergic fungal sinusitis. So this is double density sign. In this case, we have been shown an MRI, in which case there is a large tumor in the maxillary sinus on the left side, and you can see these linear hypointensities. This kind of looks like the brain, so this has been given the name of a cerebriform appearance, and this is what is an inverted papilloma. So inverted papilloma, you have the cerebriform appearance. Where else do we see cerebriform appearance? We can see it in stomach, in path, which is the condition of Menetrio's disease. You can also see a cerebriform appearance in path when we study cutaneous T-cell lymphoma. Yeah, so you have mycosis fungoides, wherein the nucleus has a cerebriform appearance, right? So those are the places of cerebriform appearance that we want to remember. Here, something that you need to know, wherein you are having a contrast enhanced MRI, and you can see how one of the turbinate is not showing any enhancement because it is completely necrosed. So this is what is called as the black turbinate sign. So this is the black turbinate sign that represents this ischemic necrosis of the turbinate that can be seen in a fungal infection, an invasive fungal infection, which is angioinvasive. So you know I am talking about mucormycosis. Okay, so mucormycosis will have ischemic necrosis, no enhancement because of its angioinvasive nature. Okay, so this takes care of neuroradiology section for us. So lots of discussions that we have done here. So let's try and recapitulate all of that. So we started off with head trauma. We know that NCCT is the best investigation here. It is showing us all acute hemorrhages except diffuse axonal injury, where MRI is investigation of choice. So NCCT is overall investigation of choice. EDH is our idly or our lens, SDH is a crescent, SAH is a star. You can also remember IVH, wherein bleeding was there inside the ventricles. We saw cerebral contusions having the white large areas inside the brain. diffuse axonal injury will have SWI, showing you black foci which are microbleeds. The scenario is very important for DI, wherein they'll tell you that the patient has a high energy trauma, following which the GCS is very low but patient otherwise is very stable. Yeah, so that was head trauma for us. We also saw the Mount Fuji sign for tension pneumocephalus here. Then we talked about stroke and vascular pathology. So remember the approach. First is always NCCT. If hemorrhage is ruled out, if patient is in window period, IV thrombolysis. Otherwise, we can go for CT, angio and CT perfusion to show us penumbra, and intra-arterial management can be planned. Here we also saw how empty delta sign looks like, empty cella looks like, empty thecal sac sign looks like. Okay. After this, we talked about lacunar stroke, we talked about hemorrhagic stroke, AV malformation. We saw the nidus, which is the hallmark of AV malformation, right? So those were the important points. We also saw quickly vein of Galen malformation and puff of smoke in moya disease, which are our pediatric conditions, right? Following this, we talked about brain tumors. So a few typical tumors: dural tail sign in meningioma, a butterfly tumor crossing the midline in GBM. We talked about vestibular schwannoma having ice cream cone appearance. We talked about pediatric cerebellar tumor, cyst with mural nodule, pilocytic astrocytoma, and fourth ventricle tumor, which was medulloblastoma. And most important, a calcified suprasellar tumor, which is craniopharyngioma, right? So this was brain tumors. Following this, few infections. So we saw an abscess, which is a ring enhancing lesion with diffusion restriction. When you have multifocal conglomerating lesion, basilar exudates, we talk about TB. When you have starry sky, multiple cyst with scolex, we talk about NCC. We saw HSV encephalitis affecting frontal temporal lobes, and then if you have HIV/AIDS patients, you want to rule out cryptococcal lesions having soap bubble appearance, toxoplasma having a target appearance, and we also saw PML having white matter involvement. After this, there were a few signs that we saw. So we saw a condition of multiple sclerosis. We saw how a Dandy Walker malformation looks like with a posterior fossa enlargement and cyst, and then there were a few salient features that we saw. Various skull x-rays to remember, right? So on the skull x-rays, you want to remember salt and pepper, punched out appearance of skull in multiple myeloma, LCH having a geographical lytic lesion, Sturge-Weber with tram track appearance, raised ICP in copper beaten skull, right? So those were the skull x-rays that we had seen. Following this, we saw a few orbital and PNS pathologies. Okay, so this is in a nutshell our neuroradiology. So now a quick summary of the must know images. So here you can see in head trauma how we have seen on the right side extradural hematoma, a lens shape or your idli shaped hematoma. On the left side we have a subdural hemorrhage having a banana or a crescent shape. A skull x-ray with hair on end appearance. So this is sickle cell anemia or thalassemia or any hemolytic anemia. In context of trauma, low GCS but CT being normal or showing petechial hemorrhages, this is diffuse axonal injury showing micro bleeds. A hypertensive elderly patient having a bleed in the putamen. So this is the lentiform nucleus and this is the putaminal intracranial hematoma because of hypertension being the most common risk factors. This is an image which you must have studied in ENT, so I have not discussed at length but just included here just for completion's sake. So what we are seeing here is the Hohmann-Miller sign, which is seen in a juvenile nasal angiofibroma, which is a vascular mass when adolescent would present with epistaxis, adolescent male exclusively would present with epistaxis, and you have a tumor in the infratemporal fossa here which is pushing on the right maxillary sinus and causing bowing of the posterior wall. This is the Hohmann-Miller sign. What we have here is a cystic suprasellar mass lesion, which is a craniopharyngioma. So cystic with calcification in a child, all C's. This is craniopharyngioma. You see a white star of death. Yeah, so this is acute subarachnoid hemorrhage, which could be because of trauma or spontaneous because of aneurysm rupture. You see multifocal starry sky appearance. You see white cyst with a central scolex. So this is neurocysticercosis, right? So these are the must know images from neuroradiology. Now let's have a look at the previous year questions very quickly. A 36-year-old male underwent a road traffic accident. You see the NCCT having this lens-shaped hematoma. So this is EDH. 34-year-old woman landed up in Ames emergency after a road traffic accident with a GCS of 3. She was intubated and sent for NCCT, which was found to be normal, right? So very typical history. This is diffuse axonal injury, wherein investigation of choice is MRI, sequence SWI. Following is most likely to be seen due to rupture of saccular aneurysm in the brain. So berry-aneurysm, saccular aneurysm, it is subarachnoid hemorrhage. 35-year-old female with thunderclap headache. So similar question, see how they've just changed the pattern, but answer is the same here. So this is a star of death that you are seeing. This is a subarachnoid hemorrhage. 56-year-old male with sudden onset right hemiplegia. You can see this putaminal bleed. So this is what is hypertensive hemorrhage. Berry aneurysm would lead to SAH. This is not in the pons or the ventricles, okay? What is the likely diagnosis? So you can see that there is the hypodensity here, which is a small volume hypodensity in the thalamus, right? On the two sides of the third ventricle, we have the thalamus. This small volume stroke is a lacunar stroke. This is not hyperdense, so this is not hemorrhage, and the MCA territory is not involved. And also, can you distinguish embolic versus thrombotic stroke on imaging? Not really, okay? So you can anyways rule these options out that we cannot distinguish them. So both of them must be wrong, okay? So this is a lacunar stroke. Which arterial territory is involved? So you can see that this is the middle cerebral artery. Yeah, so we can see it's an MCA stroke, but we can't say whether it's an embolic or a thrombotic stroke, right? So this is the MCA territory. If the hypodensity was here, ACA. If it was here, that would have been PCA, and the vertebral artery would involve the brain stem. So you would have medullary infarct in this case, okay, not cortical infarct. A patient presents to the ED with chronic ear discharge and headache with ear pain. CT revealed the following findings. What is the diagnosis? So on the CT, you have this large ring enhancing lesion. This is an abscess for sure. But that is not what they are asking. They are actually asking me anatomy. Where is this abscess located? Is it in the temporal lobe? Yes. So this is the left temporal lobe. It is not extradural. It is not subdural. It is not cerebellar. If it was cerebellar, it would be here, right? 10-year-old child presents to the ED with sudden onset vision loss in bilateral temporal field. So child with bitemporal hemianopia, straight away a bell should ring in your mind, that is craniopharyngioma. The CT further helps you see the lesion with calcification. This is craniopharyngioma. 35-year-old male with seizures. What is the likely diagnosis? You can see multifocal starry sky lesion. So it's not just NCC, even in the muscles can you see these lesions? So these are all cysticercosis, alright. So this is neuro plus myocysticercosis, okay. Gold standard investigation prior to FES. So prior to FES, the investigation of choice is a high resolution CT. If that's not in the option, we go for CT. A patient presented with history of diplopia and restricted eye movements. What is the CT showing us? So on the CT, you can see how there is the fracture of the floor of the orbit here. So this is a blowout fracture. If there was a fracture here, we would say it's a zygomatic fracture. If it was a fracture involving the maxilla, it would be a maxillary fracture. A leaf foot fracture, remember, is a multiple complex fracture of the face wherein you have multiple planes So Lefort 1 would be somewhere around here, involving the maxilla and the base of the palate. Lefort 2 would involve the orbit, and Lefort 3 is what causes a complete craniofacial disjunction. Okay, so you will have a complicated fracture complex in Lefort. So this is a simple blowout which has been asked in a lot of times in the recent exams. Okay, so it's very important. 15-year-old male patient presenting with epistaxis underwent a CCT. So what are we seeing? Seeing a Hohmann-Miller sign of JNA, which is the bowing of the posterior wall of maxillary sinus. Remember, the Dodd sign is something that you would see to distinguish an anterochoanal polyp versus a JNS. Here, a lateral X-ray of the face would be provided, and if you see that there is a polypoidal lesion surrounded by air coming out from the pharynx, that is a polyp. If it is attached to the posterior wall, that is JNA. Okay, so that is what is the Dodd sign. The Phelps sign is again an ENT sign wherein you have the erosion of the jugular spine. So the jugular spine is eroded in glomus tumor. So in glomus jugulae, when you have the erosion, that is called as the Phelps sign. And Greisinger sign is where you have hemorrhage and bruising behind the ear at the mastoid. So there is hematoma at the mastoid, and this is a sign that is seen when you have a complication of CSOM in the form of lateral sinus thrombosis. So because of lateral sinus thrombosis, you have this bruising behind the ear at the mastoid, which is the Greisinger sign. Okay, so these are the other signs of ENT we need to be aware of. Identify the anatomical variation here. So what are we seeing? This is the inferior turbinate, this is the middle turbinate, and you can see how the superior turbinate now has air. So this is pneumatized superior turbinate. We can never see onodi in this plane, right? Onodi is posterior. It is not infraorbital, so not halar and not concha bullosa, because it is not the middle turbinate which is pneumatized. Okay, this is pneumatized superior turbinate. In fact, in the recent times, in all AIMS exams, you used to have one of these PNS anatomy variants which was being asked. Hasn't been asked in the last 1 year, but before that there were a lot of questions on this. A 65-year-old non-smoker male presented with nasal blockade and occasional blood mixed nasal discharge. The radiological and endoscopic findings have been shown. What is the likely diagnosis? So you can see how there is this hyper intense mass with this cerebriform appearance. Even on endoscopy you are seeing the cerebriform appearance. So this is an inverted papilloma. JNA can almost be excluded, won't be seen in a 65-year-old male. A cancer could be seen in this age group but will not have this orientation. It will be a very invasive lesion, and they would show you a CT which is having erosions of the bone. Bone is getting destroyed, tissue planes are getting destroyed is the kind of imaging that would be provided. Esthesioneuroblastoma is also an anterior skull-based tumor. So they'll show you a tumor which has epicenter here. It's going into the brain from the cribriform plate. Yeah, so esthesioneuroblastoma is actually a neuroblastoma. It's a tumor that's arising from the olfactory neurons. Okay, so it would be going along the cribriform plate into the anterior frontal lobes. Okay. A 35-year-old trumpet blower presents with a neck swelling. What is the likely diagnosis? So in fact, the occupation itself is a giveaway. When you have this air-filled outpouching in the neck, it is a laryngocele. It's an external laryngocele. A thyroglossal cyst, a brachial cleft cyst. Remember, anytime they are asking you a cyst, they would always give you an ultrasound. We can't diagnose a cyst on X-ray. Yeah? So straight away you can rule them out. And carotid body tumor again won't be able to be diagnosed on a X-ray. Okay, so this is a laryngocele. This is one of the more difficult questions that had been asked in the AIMS exam, wherein they asked you a radiological staging of CA larynx. So here you've been given the CT image and you can see that there is a tumor in the larynx which is going out and eroding the thyroid cartilage. So remember, when we study CA larynx staging, we've also done this in BTR. Want to remember that when it erodes out of the CA larynx and it invades both the cortices, this becomes T5. T4. Only when the inner cortex is eroded, that is T3. When it goes to both of the cortices of the cartilage, that is T4. Okay, so that is the answer here. Tigroid pattern, so they are not asking eye of tiger, be careful. Tigroid, this is Pelizaeus Morse Becker, or the other differential is metachromatic leukodystrophy. Wilson's would show you face of panda sign. A newborn baby born with congestive heart failure, yeah, so big hint here. And when they show you brain imaging with this large vessel, this is vein of Galen malformation. Empty thecal sac sign is seen in arachnoiditis, right? So this is also an old Ames question. Because of arachnoiditis, the neural elements are going to adhere and you will have an empty thecal sac appearance. Okay, so that takes care of neuroradiology for us. No motivation, but one exam tip for you. A lot of times, you know, when we are going for the exam, students have given so many GTs and so many mock tests, or you know, a lot of repeaters. Carry the baggage, as I like to call it, of your past exam scores and ranks. You know, you feel that that is what defines you, that this is what I can do, or this is what I'm an average student, is what a lot of students say. Come and tell me that, ma'am, I'm an average student, this is what my rank has been, this is what my GT scores have been, and my GT scores are stuck in this bracket of 100, 120, and the same thing is going to happen to me in the actual exam. But that is so not true, right? So stop defining yourself with those ranks. Just forget about it, and every exam gives you an opportunity to do a completely different performance, right? So what you want to do is forget everything about it, learn from your mistakes for sure. That is the takeaway. Learn from the mistakes, but forget the marks, forget the number. Stop defining yourself with that number. It's only when you let go of that, you're gonna start regaining that confidence that you can improve, that you're gonna do something magical, right? So that is what we are all out here to tell you, that we're gonna improve slowly with baby steps, but definitely gonna improve, right? So first of all, just let go of that, learn from where you went wrong and improve that, but just stop focusing on the number. Okay, so thank you so much, and we'll meet in the next lecture. Thank you.